All right, so we're now going to hear from Adrian Banning from the UK, and I mean from the UK, literally from the UK, and Adrian unfortunately could not be here, but he has done a lot of the pivotal phase 1 and phase 2 work of PiCSO. And so let's see if we can launch this. Okay, here we go. I see it there. There we go, okay.
Hi, it's great to be
Terrific.
part of CRT this year. I'm very sorry I can't be with you in Washington, but I'm looking forward to discussing with you my experience of the PiCSO technology. These are my declaration of interests. As we've been hearing from Tim, there is a recognition that although we've improved our treatment for myocardial infarction over the last decade, we are now seeing a plateau of our outcomes, and frustratingly, there really still is a need for improvement in the technology and the way in which we look after people with heart attack, in particular to reduce the risk of mortality, but also the incidence of heart failure. We've heard from Greg about the importance of the microcirculation, and we recognise, of course, that people with big anterior infarcts, particularly when it's TIMI 0 or TIMI 1, are most at risk of the consequences of infarction and the likelihood that that's going to proceed to either arrhythmic death or heart failure death. So I'm going to talk to you today about PiCSO, which is a novel first-line therapy used during MI to positively try and change the course for AMI patients. This picture is a picture of the console, and you can see the balloon highlighted there. So the origin of this technology goes back many years. This cartoon comes from a paper published in 1948, where people looked at the potential to graft an arterial graft onto the coronary vein and occlude the coronary sinus in order to improve flow in the myocardium when it was deprived of its normal coronary artery supply. Clearly, that's not practical in the long term for most patients, but these micrographs show the effects of acute ischemia in a canine model. Top left, panel A is the control. You can see the impact of LAD occlusion in panel B and panel C. And in panel D, you see the impact of coronary sinus occlusion with a reduction in the area of the blue stain there. And during the coronary artery sinus occlusion, really much less ischemia and consequently much less likelihood of infarction. And you see the impact of releasing the coronary sinus ligation in panel E. So this is the coronary sinus balloon. We hypothesize that the mechanism of this action is to redistribute blood to the deprived myocardial areas, to improve myocardial microcirculatory perfusion, and potentially to enhance the washout of deleterious agents from the microcirculation. This technology goes back at least 10 years, and you can see the growing body of evidence in these papers that have been published here. But perhaps importantly, getting down to the clinical data that we have, this data coming from patients with acute coronary syndrome suggesting a 33% relative infarct size reduction in STEMI patients when we use the PiCSO technology. And in fact, if you drill down on that, you can see up to 31 down to 16% in this analysis using analyzed controlled patients from a meta-analysis that Greg did some years ago. So the potential for a substantial reduction in infarct size up to nearly 50% in those patients with the biggest infarcts, anterior STEMI, with TIMI 0, TIMI 1 flow. So this was the basis of our OXAMI PiCSO study, which we undertook a couple of years ago. We took patients presenting with acute anterior myocardial infarction, we restored flow, and we then measured IMR. In those patients with a high IMR, they went on to have PiCSO treatment, and we compared them with a control group, which we already had from a previous study. In those patients presenting with a low IMR, we also followed them through in order to have a third comparison, but these patients were not treated actively with PiCSO. So ultimately, we had 3 limbs. We had high IMR treated with PiCSO, high IMR as a control, and low IMR. This is a typical case. We can see a patient presenting with acute anterior infarction with occlusion of the LAD. Passage of the wire does result in some restoration of flow. Pre-dilatation in a standard fashion with pretty much TIMI 3 flow after balloon dilatation. We then measure IMR, and you can see the flow dilution curves on the left-hand side there. And you can see we've got pretty good flow there. And if you watch the angiogram following through, you start to see the coronary sinus pacifying, and we use that view to give us insights into where to place the catheters in order to undertake the PiCSO therapy. You see the coronary sinus starting to come up just here on the angiogram on the right-hand side there. So we then place the PiCSO balloon, and you can see that being placed in the left-hand panel. And you can see how PiCSO therapy works on the right-hand panel there with this phasic increase in coronary sinus pressure during balloon inflation. This increase in pressure here, the balloon is up. And then once the balloon comes down now, you see the pressure coming down. And then once the balloon comes up again, just there, we now see this cyclical increase in pressure there. So after the appropriate duration of PiCSO therapy, we then proceed to stenting. In this patient, 2 stents were required to get a good angiographic result. You can see that in the right-hand panel. And you can see pretty good flow in the left-hand panel there. And at that point, we would repeat IMR measurement. And in this patient, the IMR has now fallen down to 22. This is an MRI taken in a patient 48 hours in the top panel. You can see a large area at risk, up to nearly 50% of infarct size potentially. And the 6-month scan showing a final infarct size of 20%. Just to drill down a little on that PiCSO screen, you can see this phasic increase in pressure during balloon inflation. Balloon is deflated now, pressure is lower, and then as the balloon comes up, we see increasing phasic pressure in the coronary sinus, and it starts to fall as the balloon goes down again. And in this case, we mark the inflation of the balloon in the LAD just there, which is interesting because if you see we've got normal pressure now, but you'll see the next cycle, the pressure in the coronary sinus does not go as high. Just this is it coming through here now. You see this attenuated response because we've got less flow. The LADs are currently occluded by the stenting balloon. But once that's released again, we then see that resumption of phasic increases in pressure up to a peak there. So what were the results of ophthalmic PiCSO? Well, the first thing is it was safe. We were successfully able to cannulate the coronary sinus in most of the patients. Predictably, there was an increase in procedure time, but much of that related to the time taken for PiCSO to be delivered. Coronary sinus cannulation was relatively straightforward and really didn't take very long at all. And these were the results. This is the data on IMR. And we see these 3 groups. We see the brown group, which is our control high IMR. We see the blue group, which is our high IMR PiCSO treatment. And we see the green group, which is the control with low IMR to begin with. And we see that at pre-stenting, similar levels of IMR, but a significant reduction in IMR, particularly at 24 to 48 hours when IMR was repeated, suggesting potential advantageous effect of PiCSO on microcirculatory function. And that's borne through when we look at final MRI results of infarct size. You see this similar size infarcts presentation in brown and blue for the high IMR control and the blue PiCSO, but a significant reduction in final infarct size of 33 in control down to 26 with PiCSO, which represents nearly 50% reduction in infarct size. And when we look at the multivariate predictors of outcome, we see that treatment with PiCSO came out very strongly there. So this is the program going forward with regard for Miracor and this therapy. We are now recruiting PiCSO AMI-1 in Europe, and we will move on to a US trial, and then we'll also perhaps have a further European trial in France. And we hope to recruit over 700 patients to randomized trials over the next 4 years. PiCSO AMI, as I said, is currently recruiting. We intend to randomize 144 patients, randomized 1-to-1. These will all be LAD, proximal LAD with TIMI 0, TIMI 1, and the primary endpoint is infarct size as a percentage of LV using MRI at 5 days. And this trial is recruiting very efficiently despite the challenges that COVID has brought to us. These are the primary endpoints, and as you can see, the secondary efficacy endpoints, including clinical outcome, heart failure, and the like. So I hope I've given you a taste of what PiCSO therapy may offer for us. I would suggest that we've reached a plateau of effectiveness for PPCI therapy using just conventional balloon stents and anticoagulants, and I'm afraid that plateau is suboptimal. We need additional therapies, and in my view, we need a targeted application of these therapies to demonstrate efficacy rather than an all-comers approach. PiCSO is a novel and exciting therapy that could improve outcomes in PPCI, and in that selected group, I think it could have a significant role in those patients who are at the highest risk of an adverse outcome. We look forward to discussing further results of this PiCSO therapy as years pass, and hopefully face-to-face. Thanks for your attention.
Great, you just applauded a videotape.